So now it is my pleasure to introduce my co-director of this course, Dr. Sharon Hung. Dr. Hung received her MD degree at Northwestern Feinberg School of Medicine, completed her internal medicine residency training at Cedars-Sinai. She is board certified in internal medicine, and she practices in a primary care setting here at Stanford, where she also is the director of women's health for primary care and population health. In this role, she creates educational resources for primary care providers. She leads a fantastic osteoporosis group for patients, and she is the host of the Stanford CME's Women's Health podcast, which can be found on YouTube. So Dr. Hung is going to enlighten us now about weight gain in menopause, which we never talk about with our patients, right? Boy, so really happy to hear and learn from you, Dr. Hung.
Great. Thank you so much, Karen. All right, so I have no disclosures, but I will be mentioning some brand names since they pertain to insurance coverage. This is our roadmap for the next 35 minutes. I'll go over obesity definitions, the effects of weight from menopause versus aging, weight loss medications, addressing barriers to GLP-1 use, and how we should counsel patients on diet and exercise. We all know there's certainly limitations to using BMI, like it's not an accurate predictor of fat mass, but it's still a quickest and most cost-effective way to screen, and a normal BMI has been associated with better health outcomes. A quick update, we're no longer using the term morbid obesity, so for your patients who have a BMI of over 40, that should be just class 3 obesity now. And do remember to lower each threshold for counseling and treatment by 2 kilograms per meter squared for our Asian population, since the health risks that are associated with being overweight and obese do occur at lower BMIs in these populations. While I'll be referring to BMI as a framework because that's how we study and use weight loss medications, I also wanted to share this obesity definition to set the tone for today's talk, since I think it's much more reflective of how we should be approaching obesity. Obesity is a chronic, relapsing, multifactorial neurobehavioral disease wherein an increase in body fat promotes adipose tissue dysfunction and abnormal fat mass physical forces, resulting in adverse metabolic, biochemical, and psychosocial health consequences. On the right, I've taken this chart from a picture with patient-preferred terms. So for our patients who have class 3 obesity, we should be using terms like your weight or your BMI and not your excess fat or obesity, even though I'm going to be using that term a lot today. Obesity has been increasing at staggering rates, tripling in the last few decades. In some states, obesity rates are as high as 45%. So given this magnitude, I'm glad you're all here today because we can't defer treatment of this widespread condition that increases cardiovascular mortality to our overburdened weight loss specialists. Obesity rates are slightly higher in women, and as you can see, that class 3 obesity in the light orange is much more common in women than in men. We don't have any conclusive explanation for this, but it's thought that fluctuations in sex hormones at different stages of our reproductive life may play a role in that adipose tissue dysfunction. And the prevalence of obesity, as I noted below, for the midlife women that we're talking about today is at 42% have a BMI of over 30. So many people ask, is weight gain related to menopause or aging? And it's somewhat a combination of both. After the third and fourth decade, muscle mass loss occurs at about 3 to 8% per decade. And that's seen independent of menopausal status. So whether someone's pre, peri, or postmenopausal, they will gain that amount of weight through midlife and slightly beyond as well. And so weight gain will occur if dietary habits remain unchanged because we have a lower basal metabolic rate and resting metabolic rate. And so if you eat the same, you're naturally going to gain more weight. Estrogen acts directly on muscle stem cells to promote muscle generation and repair, and estrogen depletion favors central fat abdominal accumulation and that visceral fat accumulation, which are very closely tied to cardiovascular risk. There are many risks that are associated with the menopausal weight gain that have been touched upon today. Aging, weight gain, and menopause all independently increase cardiovascular risk. Menopause itself directly increases LDL, also HDL, but HDL starts to lose its protective effect and is more dysfunctional, so it's not necessarily reassuring to see. MASLD, a few people had asked questions about earlier, is a favorite topic of mine. So I'll just say it does double in postmenopausal women, but the rates actually stay the same for men in their 50s. So there's something specific about menopause that increases MASLD rates. In terms of cancer risk, being overweight or obese not only increases breast, endometrial, and ovarian cancer, but various GI cancers like colon, esophageal, liver, pancreatic. For mechanical complications, there's something very pro-inflammatory about being overweight, and so we see worsening OA not just in those weight-bearing joints, but also, for example, the hand joints. Estrogen and progesterone have protective effects on the upper airway muscles and the lower esophageal sphincter tone, so those rates also increase in menopause, but also with subsequent weight gain. Excess adiposity is associated with higher prevalence of depression, decreased life satisfaction, and we have already talked about how weight gain is associated with worsening menopausal symptoms such as vasomotor symptoms. The exact mechanism there is a little bit unclear, but it's thought that impaired thermoregulation from the excess weight may in part explain increased rates of vasomotor symptoms. And there is evidence that weight loss helps decrease the number and intensity of vasomotor symptoms. So again, I think a few of you have asked in the chat, if we see all those changes during menopause, then how can menopausal hormone help with that midlife weight gain? And menopausal hormone therapy has been associated with decreased visceral and total adiposity, less muscle mass loss, improved metabolic parameters such as insulin resistance, but the effect size that we've seen so far is small. And so MHT should not be prescribed for concern of body composition or weight gain alone, but if your patient is going on it for another indication, you can at least reassure them that it's considered weight neutral. Next, I'll dive into weight loss pharmacotherapy, which we start to consider, of course, after talking about comprehensive lifestyle intervention, which I'll go over later, for patients with BMI over 30 or over 27 with a weight-related comorbidity such as hypertension, hyperlipidemia, OSA, etc. But first, I want to emphasize that we should do no harm. And by that, I mean that many patients are on medications that that promote weight gain or make it difficult for them to lose weight. For diabetes, of course, now we have GLP-1 agonists and SGLT2 inhibitors, which have been shown to contribute to weight loss. In terms of hypertension, angiotensin is overexpressed in obesity and directly contributes to obesity-related hypertension, which supports the use as ACE or ARBs as a preferred first-line agent. Calcium channel blockers like amlodipine are at least considered weight neutral. I'll put a quick plug here because I feel like I inherit a lot of patients on agents like atenolol and metoprolol, and those do promote weight gain. And most of the time, in my experience, patients don't necessarily need to be on a beta blocker, but if they do have a history of heart failure, arrhythmia, MI within the last 3 years, and they need to be on a beta blocker, you may want to consider carvedilol with close consultation with their cardiologist to see if that would be more appropriate for them. For the antidepressants, I came across a lot of varying literature based on the meta-analysis I was looking at. So I've bolded the agents here that are consistently shown to be in the category that I've put them in this chart. So paroxetine, amitriptyline, mirtazapine, and lithium are consistently shown to increase weight, whereas bupropion is consistently shown to cause weight loss. In terms of other agents that we use quite commonly for concurrent depression and anxiety, for example, I use a lot of sertraline and escitalopram. Those are at least considered probably weight neutral in most studies, but certainly I recognize that everyone responds differently to those medications, and so you may find that your patient may gain weight on some of those agents and you may need to consider another one. Work carefully with your patient's psychiatrist and neurologist to see if there's an antipsychotic or anti-epileptic that may be more weight neutral. I'll at least mention here for gabapentin, we use that a lot as primary care providers for various off-label reasons, and sometimes patients aren't even sure if it's benefiting them or why they're still on it, so one to consider revisiting. So next, I'll talk about GLP-1 agonists. They exert their effects on various organs. They work on the CNS to reduce appetite, decrease food-seeking behavior. They work on the stomach to reduce slowing through the stomachs to increase satiety, but they also act on the pancreas, the muscle, and the liver to improve insulin secretion and sensitivity, and have anti-inflammatory effects on the heart. Semaglutide and liraglutide were the first ones that are approved for weight loss, and we saw a 15% decrease in mean body weight loss on the maximum dose of semaglutide 2.4. And then we had terzepatide, which was a dual GLP-1 and GIP agonist. And in the SURMOUNT trial, we saw a mean weight loss of 20%. So as a reminder, some of your patients may lose a lot less than 20%, and some may lose more. I also want to point out here that certainly a lot of patients are needle phobic, even though the Wegovy pens are pretty small and benign. But for patients who really don't want to see a needle at all the terzepatide pens, so Mounjaro and Zepbound, the needle is completely hidden. And it is so critical to discuss these GLP-1 agonists with our patients since they have been shown to reduce major adverse cardiac events. Cardiovascular disease is the leading cause of death in women, and only half of women are aware of that. I think most think that they have a higher risk of things like cancer or breast cancer. And there's a notable increased risk of cardiovascular risk after menopause. So liraglutide, semaglutide, dulaglutide have all been approved for MACE reduction in overweight and obese patients who don't have diabetes. The MACE reduction trial on terzepatide and oral semaglutide is ongoing, but those I think will likely be quite promising. This is our current landscape of GLP-1 agonists that are approved for weight loss. I've made this chart in descending order of efficacy for weight loss. So we'll talk about contraindications. Medullary thyroid cancer and MEN2 is on the box, but it's very rare that patients have a history of medullary. It's only about 5 to 8% of all thyroid cancer cases are medullary. And so if I ask them about a family history of thyroid cancer, they say yes. Most of the time that's going to be papillary, and I do have them kind of investigate what thyroid cancer that exactly was. In terms of pancreatitis, I also see that as more of a relative contraindication. So for example, if they've had a history of hypertriglyceridemia related pancreatitis and the triglycerides are now well controlled, we talk about how the risk of recurrence is probably very small. Pregnancy I've added here because it just hasn't been well studied in adults who are pregnant, so I would not use them at that time. And then caution, of course, given the mechanism of action in your patients with underlying gastroparesis or a history of small bowel obstruction. And next, I want to point your attention to the special considerations because I think a lot of patients are hesitant to go on a medication where they feel like it's really just their willpower and they don't necessarily need to go on a medication, but there's a lot of other benefits to GLP-1 use. As you all know, this is already approved. This is first approved in our DM2 patients, but also in the SURMOUNT trial, they found that it reduced the hypoxia burden in OSA, and it so has been FDA and Medicare approved for treatment of OSA. In cardiovascular risk, I've talked about in the Step 9 trial, semaglutide was associated with decreased pain and knee osteoarthritis. In the FLOW trial, semaglutide reduced the risk of kidney-related adverse events in diabetic patients and is FDA approved for CKD in diabetic patients. In the ESSENCE trial, that's our first trial on MASLD so far that showed not only MASH resolution, but also fibrosis improvement. EVOKE, I put here in italics just because it's still in stage 3, but I think it's very interesting that they're investigating the neuroprotective effects of GLP-1 agonists for early Alzheimer's, and exenatide is being studied for Parkinson's. That one I think is in phase 2. And recently, a JAMA Psychiatry article showed that weekly semaglutide also decreased alcohol overuse. And so again, I've bolded the ones that have FDA indications, but there are so many benefits of GLP-1 agonists that we are still learning about. There are also just numerous agents on the pipeline, which I hope will expand access in the future. The next generation of obesity medications will be targeting other enteropancreatic hormones and have complementary and synergistic potential. So for example, you'll start to see some amylin targets. Amylin, it plays a role in postprandial satiety regulation. I'll point your attention to the green at the top, just because, again, I think a lot of patients are still reticent about injections, even though they're pretty minuscule. So the oral GLP-1s are currently in phase 3 trials already, including oral semaglutide, which many of us use for diabetes, but those doses for diabetes only go up to 14 milligrams, where we use doses of 50 milligrams for oral semaglutide, and we're seeing a similar weight loss effect as injections in our preliminary studies. I'll also just highlight retatrutide because I think it's another agent that's pretty close to coming onto the pipeline. And this is a triple agonist for weight loss. So in addition to the 2 targets of terzepatide, it also acts on the glucagon receptor, which reduces food intake and increases energy expenditure. And here we see on the maximum dose, 24% decrease in mean body weight. That is so impressive because that starts to near the effect of some of our less invasive bariatric procedures, such as intragastric balloon. But even though these medications are so amazing, I think there's a number of barriers to addressing their use, which I'll go over. The first one is, of course, insurance coverage. And I tell patients who are hesitant, honestly, the biggest barrier is insurance coverage. And if we can get past that, then we should really consider it. Private insurance coverage varies so much with individual plan. I let patients know I don't know until I send it in. Medicare does not cover weight loss medications. Medicaid does, but just in 16 states, California being one of them. In terms of tips, just make sure, one, sometimes I just send in the wrong one, like I send in Mounjaro instead of Zepbound, and so changing it to the formulation that's FDA approved, and then making sure you're attaching a code to the order that's FDA approved. So for example, stage 1 obesity or whatever their BMI is. And then carefully documenting. So they're starting BMI on the medications and also their progress. I have started to run into the issue where insurances won't cover refills of a medication dose that someone's been on because there was no recent in-office measurement. So our protocol now is to bring in patients every 3 months so that I can have a BMI that's in the chart. And then in turn, a lot of insurances also require having engaged in a weight loss program for 3 to 6 months. For most insurances, I have found that this is pretty liberal. So if they've engaged in any sort of weight loss class or exercise or diet regimen in the past, I try to document that as well as I can. But I also use that as an excuse to have them work with one of our nutritionists. Again, I think patients are often hesitant because they're like, oh, I know what I need to do. But I say, if I can document that you're working with a nutritionist, that will be quite helpful. And then I counsel my patients to ask me for refills 1 week before it is due, not only to let me know if they're tolerating it so that I know whether or not to send up the next dose, but also I have found that sometimes they require a whole new prior auth for the next dose, so that just gives my team a little bit more time. If the insurance does not cover weight loss medications at all, there's 3 options to obtaining GLP-1 agonists. One, liraglutide is now generic, but that's still $524 for a 1-month supply, and it is limited by being a daily injection. Cost savings cards are available online, but that's still, again, is $650 per month. And lastly, Zepbound vials. Zepbound vials are available. You do have to order it for your patients. They had just recently expanded the dosage to include the 7.5 and 10 milligrams, which were not previously available, and they lowered the cost a little bit, but still, again, $350 to $500 per month. And you do need to attach an ICD-10 code order and send it to Lilly Direct Cash Pay Pharmacy Solutions, which should be in your electronic health record. And then patients will receive an email or a text to complete that order. I'll just note here, sometimes patients will mention, oh, well, I'm just going to get it from, this person who's offering me compounded solution, and that's just not recommended due to safety concerns. If Shortages, I feel like, at least in our area, haven't been as much of an issue this year compared to last year, but still, I wanted to bring this up. If your patient happens to miss 1 or 2 doses, they can restart at the same dose. They do not necessarily need to start over, but if you do find that you need to have other coverage in the meantime, then this is something, a dose equivalency chart from a diabetic journal that you could use for reference. I also use this chart if I'm thinking about switching someone to a different agent. There's not really been shown whether one GLP-1 agonist is better tolerated than another. Anecdotally, people might just tolerate a better one. And so if they're having GI side effects to one, certainly reasonable to switch to another. Another common situation I come across is patients aren't getting enough weight loss on semaglutide 2.4. And after, of course, reviewing their lifestyle factors, perhaps I can switch them directly to a terzepatide 7.5 next if they had no GI issues with the semaglutide 2.4. But of course, $500 to $600 a month is still not, it's just not doable for the majority of patients. So I put this chart together just to kind of compare the GLP-1 agonist effective weight loss compared to some of the other oral medications that have been in the pipeline for some time. I won't read through all of this. This is mainly for your clinical reference. I'll just say here that, if a patient's insurance doesn't cover weight loss medications, in my experience, they're not going to cover Qsymia or Contrave. And so I have always prescribe this pill separately. So as you can see here, if your patient's interested in Qsymia, then just separating the phentermine and topiramate is just $16 a month, so affordable for most people. And while it's not FDA approved, our weight loss clinic does a lot of mixing and matching, which is another benefit when you separate them out. So for example, if you have a patient with migraines and some, depression, then perhaps a mix of topiramate and bupropion, or even throwing in some metformin, which is not FDA approved for weight loss, but if they have prediabetes, that can cause 2 to 4% among weight loss. Next, patient education. Again, this is something I hope is clinically useful. I'll focus my discussion here on the right in terms of those GI side effects. Those are the most common side effects your patients are going to get. So I counsel before I even send in the first prescription, reduce your meal size. Don't eat until you're totally full. Begin each meal with a protein. Don't eat anything fatty or greasy, and then making sure you're getting enough fiber or adding in Docusate if you're feeling some constipation. And with proper counseling and nutritional changes, very few patients need to stop it. And that's seen in the step 1 and surmount trials of semaglutide and terzepatide, where the discontinuation rates for GI side effects was only 4 to 7%. In my experience, the GI side effects, something just prevent me from going to the highest dose for them, but most patients should be able to tolerate a mid-level dose with the proper nutritional counseling. And next, I want to talk about what happens when you stop a GLP-1 agonist. And so in the step 1 trial, in the step 1 extension trial, they withdrew semaglutide 2.4 after a year of use, and participants regained 2/3 of the weight that they had lost, and any benefits that they saw in cardiometabolic profiles, like their A1C, lipids, etc., also all reverted back to close to normal. And I suspect that if this were to have continued, the study were to have continued, they probably would have regained almost all of that weight. And I say that just based on other trials we've had on other agents like Topamax and Orlistat, where patients regained all the weight they lost within 5 years. And so this really, again, highlights that obesity is a chronic relapsing disease. And just like a lot of our patients need statins lifelong or blood pressure medications lifelong, a lot of them will need to be on a GLP-1 agonist lifelong as well. Because there's just a lot of patients feel, okay, well, once I get to my goal weight, it's just a matter of me eating right and doing the right thing to maintain that weight. And I tell them that there's multi-system signaling of our autonomic, endocrine, nervous system, muscles, all favoring weight regain. And so it's just very difficult. Some patients do want to taper off, and this is an area that it's being studied, but some recommendations that I've heard from endocrinologists are to keep on the GLP-1 agonist for at least 6 to 12 months so that they can kind of reset their goal set, their weight set point, and then you can gradually taper down as slowly as you went up. So going down on each dose by a couple of months, making sure their weight is stable before going down any further. In terms of exercise, it's very important for patients to reach their minimum cardiovascular requirements, but generally they don't lose weight with just cardio alone unless they're also restricting their calories. But of course, they should be doing cardio for general cardiometabolic health and reducing visceral muscle adiposity. Numerous studies have looked at the effect on GLP-1 agonists on body composition, and they've shown that on GLP-1s, people lose the weight that they lose, about 25 to 40% of it is lean body mass, such as muscle. And that's not necessarily unique to GLP-1 agonists. We see that with just weight loss in general. But we have seen that the amount of muscle mass that's lost on a year and a half of semaglutide is equivalent to a decade of muscle mass loss. And yo-yo dieting is even worse. And so I generally, also counsel patients on that because every time you lose weight, you lose a lot of muscle, but when you regain, a lot of that is fat. And so the proportion of muscle is even lower if someone is going up and down over the years. So what can we do about that? So for patients who are on a weight loss program or using GLP-1 agonist, resistance training is very important to do and has been shown to decrease the amount of muscle mass that they lose compared to just doing endurance or cardio training. There's not a lot of evidence specific to GLP-1 use and how we should be recommending exercise yet, but in this one study with liraglutide, they found that if people were on liraglutide and combined cardio and strength, they had the greatest amount of weight loss, most increased in muscle mass, and most cognitive restraint, like eating, making the right food and exercise choices. In this chart on the left, this is a hypothesis that if patients were to have engaged in strength training more regularly during their treatment phase on the GLP-1, perhaps if they were to stop it, then they would regain less weight because that increased muscle mass would cause them to be more metabolically active and that thus regain less weight. But again, more studies are needed on how we should taper resistance training to GLP-1 therapy. And again, I would ask patients to do strength training, ideally 3 times a week, at least twice, if they're on a GLP-1 agonist or trying to lose weight, or when they're just aging and going through menopause in general. Patients often ask, well, what type of diet should I be on? And specifically to weight loss, dietary adherence is the most important predictor. So it doesn't matter if it's low carb, low fat, although generally I have patients come off of keto because it largely increases their lipids in my experience. The other important component of dietary adherence is the caloric deficit. So 300 to 500 kilocalories less than they've been eating. If we are to recommend a diet, we should at least recommend one that just reduces cardiovascular risk. Like I mentioned, the increased cardiovascular risk with obesity and with women going through menopause. So Mediterranean - a plant-based diet. Patients also ask about intermittent fasting. The data with this on whether this helps with weight loss is very mixed. It's likely only helpful if eating for a shorter window of time just helps them eat less calories overall. The other important thing to counsel about is to make sure your patient's eating enough protein. It should be about at least 30% of their total intake, and increased protein intake can attenuate the proportion of weight loss from skeletal and free mass loss. So we should probably have them increase the goal daily intake from that 0.8 that's recommended by the RDA to 1.2 grams per kilogram for women that are going through their midlife and aging, again, to support loss of lean muscle mass loss. This does not apply to our CKD patients, stage 3 to 5. They should still stay closer to 0.8 grams per kilograms. And I like telling patients to focus, they could just change their whole grains to things like quinoa and lentils, which are very protein rich, and not to get that increased protein from red meat. And just a reminder about our obesity treatment pyramid, and that bariatric surgery is still a great option for patients who have a BMI of over 40, or if they're over 35 with one of the comorbidities. With gastric bypass, we see a weight loss of 60 to 80%, which is just far beyond what we see with even our strongest medications at this time. And our bariatric team often uses GLP-1 agonists before and or after bariatric surgery, so those are not mutually exclusive options. There's not a lot of studies directly comparing the effects of bariatric surgery versus GLP-1 agonists, but I did find this one that specifically found that for patients who were diabetics, particularly of less than 10 years duration, if they had bariatric surgery instead of GLP-1s, that was associated with a 62% reduction in overall mortality. That risk reduction was likely due to the significantly increased amount of weight loss. And lastly, I want to point out that, when our patients come back to us and they've been on a GLP-1 and they're not losing any weight, right? It's, obviously we should review with them their diet and exercise, but it's not all about whether they're doing the right things. Again, can't emphasize enough that we should look out for medications that are promoting weight gain, but ask them about their sleep quality, screen for OSA. Those can really inhibit their ability to lose weight. Talk about chronic stressors and how to address that. Rule out thyroid disease on here, but I honestly, I find that very rare as a cause of difficulty losing weight. But do want to emphasize screening for mental health disorders, right? This, I find in my practice that patients don't bring that up until it's very late. And so making sure that we're catching depression, anxiety early and treating those conditions, which can obviously make a weight loss journey much more difficult. Screening for substance abuse, not just at that first visit, but at every visit, asking them particularly about their alcohol use and making sure that they have access to the services that they need. So, in summary, aging causes weight gain and muscle mass loss, but menopause contributes to increased visceral adiposity, which increases overall cardiovascular risk. Caloric restriction is essential for weight loss, but have your patients do a diet that's going to be most sustainable for them lifelong, because again, this is a chronic disease. And so, just picking some sort of fad diet for two months is not going to be that helpful long term. Advise patients to work closely along a nutritionist for maximal benefit. In our step one, surmount, all of our weight loss studies, patients are working very closely with nutritionists and having frequent touches. Critical to counsel our patients on resistance exercises 2 to 3 times a week and increasing their protein intake to 1.2 grams per kilogram to avoid lean muscle mass loss that's associated with aging and weight loss. I'm often kind of a bearer of bad news when a patient comes back and tells me they've lost 50 pounds, but they're not doing any strength. I tell them probably 40% of that was muscle. So making sure they are aware of that early. GLP-1 agonists reduce our risk of MACE, but also have benefits in heart failure, preserved ejection fraction, chronic kidney disease in our diabetics, obstructive sleep apnea, metabolic dysfunction associated steatotic liver disease, and osteoarthritis. Terzepatide is our most effective drug at this time, but there are many on the pipeline. If a insurance doesn't cover GLP-1 agonists, you can consider generic liraglutide, cost savings card, or Zepbound vials, but that's still very costly. So consider off-label combinations of individual medications for maximal cost savings, especially if they have another indication for one of those medications. Prepare patients that a maintenance dose will likely be needed to maintain weight that is lost. And I also tell them that at the first visit, because patients often change insurance or something, and you don't want them to be stuck in a situation where they're paying $1,000 a month for these meds. Remember that bariatric surgery is still the most effective with significant mortality benefit, particularly for our diabetics. And for long-term success, assess for other factors that can affect the weight set point: medications, mental health disorders, lack of sleep, OSA, stress, access to food and healthcare. Thank you.
Hmm. Wonderful, Dr. Hung. Thank you. I am going to take the questions that are really kind of up getting up generated with the likes. There's one that is, could you discuss the role of metformin in managing weight during perimenopause and whether it's considered effective or appropriate as a weight loss medication for women in this stage?
Yeah, I definitely think it's worth a try, particularly if your patient is pre-diabetic. I would still, obviously try to convince them to do a GLP-1, given the magnitude of weight loss that you can have on a GLP-1, and the magnitude of weight loss is directly proportional to the MACE reduction. But if they can't get a GLP-1 and let's say they have a touch of pre-diabetes, then metformin is a reasonable option to try. Like I said, the effect of weight loss is like 2 to 4% in studies. I mean, certainly that's better than nothing. And some patients don't have any effect. I think with any weight loss drug, remembering the recommendations that if there's no response in 3 to 6 months, then, we don't necessarily need to continue it.
Hmm. Right. And several questions about other regimens besides GLP-1s. Someone was saying if you separate out the bupropion and naltrexone, how do you dose that?
Yes, that is a great question, and I have that already because I
Mhm.
knew that was coming, and I can copy and paste that directly into into the Q&A. I think that'll be easier to read.
Oh, wonderful, wonderful.
But
Someone,
I will
oh,
say I also have them, in addition to the separate doses, I also have them stagger started. I think that's another benefit because both of them can have a lot of side effects, right?
mhm.
And so had you can't really tease out what medication it is unless you have them start one at a time.
Hmm. Yeah, I'm just becoming more and more of a fan of bupropion the more I hear about it, with, it being sex friendly and it doesn't cause pain. So it seems like a good drug. Uh, the question is there any A1C level when you should stop a GLP-1? Do you track those at all, or is there any association with that that's therapeutically relevant?
Yeah, that's a great question. And, you certainly, again, these medications are approved for non-diabetic patients, right? So their A1C is already within norm. It's not supposed to result in hypoglycemia as much as other agents such as, sulfonylureas, etc. But I have had patients had hypoglycemia on GLP-1 agonists. And so, if they're feeling like they're having any symptoms of hypoglycemia, have them check with a finger stick, or many of them are using a glucose monitor already. But sometimes that does limit. I don't think there's like a specific A1C because A1C is an average, right? And so if you don't necessarily go too low, that's not necessarily a problem. But I would say it's only been once or twice where I've had to stop it for hypoglycemia. On that note, I will say, right, your patient's sugars can drop a bit. So if they're on another agent already for diabetes, perhaps concurrently titrating down on that one to mitigate the chances of hypoglycemia, which are probably higher with whatever they've already been on before.
Yeah, great point. Great point. Question about is there an upper limit of the age that you can offer GLP-1s? Say very elderly people, late 70s, early 80s. Would any reason why you wouldn't consider it in those folks?
Yeah, that's a good question as well. And I think, a lot of times we don't have enough data in our older population, right? Like I'm talking about breast cancer screening tomorrow, and we don't have a lot of data for patients over 75 and 80, even for a topic like that. So, similarly here, I would say, particularly, I would be concerned based on their level of function. I think that would be what I would take into consideration because, like I mentioned, weight loss is strongly associated with loss in muscle mass. You mentioned I'm passionate about osteoporosis as well, and so I would worry about someone falling if they're not someone who's going to engage in strength training. And they're 75, 80, they're not going to do any strength training. I would be very, very hesitant to put them on a medication that causes them to lose muscle mass.
Oh my goodness, exactly. That's so true. And that's such a great lead into the talk after the break, which is going to be all about exercise and muscle mass. So I think that's really important because, yes, that falls are such a huge source of morbidity and mortality for our really elderly folks. The question about using GLP-1s in people who don't meet the weight criteria, like maybe overweight patients, how do you talk to those folks?
Yeah, I mean, so the FDA indications are also right if you're overweight with a BMI of 27, as long as you have one comorbidity. And I mean, in at least my practice, most people have at least one comorbidity, right? So that makes it a little bit easier to think about. I think the trickier situation I've also come across is that my Asian patients, right? So their BMIs are lower than what the FDA has approved. And even though they meet criteria based on us lowering that threshold, it's not meeting the insurance criteria. I still do try. So if an Asian patient with a BMI over 28, I've tried. A lot of times I'm not successful, and I know I've asked our weight loss specialists for tips on that, and they also have a really hard time. So I think a big hurdle is just having it approved at those lower BMIs.
Right. And what do you do when you have someone who's met the criteria and you've been treating them and then they reach their goal weight? How do you manage them after that? And is insurance, and does that become an issue then?
Yeah, I have certainly had it become an issue for some patients, and I'll write a long letter about their starting weight, and then the progress that they've made on the medications for them to continue. And I have most of the time been successful in keeping patients on for maintenance with that, again, that very, very careful documentation of care. Pre-medication weight and current weight. And then it's up to the patient. We have a discussion about whether, some patients just want to stay on it forever, right? They've never experienced something so life-changing, right? They're like, oh, I've never had so little food chatter or food thought. And most patients want to stay on it. I haven't had too many ask about taper. It's really the patients who haven't started it yet who ask me about tapering at the end. But once people are on it, most of them want to stay on. But again, if patients are interested in tapering, they've met their goal weight, we should keep them at their weight for about at least 6 months to reset the weight set point, and then talk about a gradual taper down to the lowest dose that keeps them at their goal weight.
And when you say gradual, do you mean keep them at that weekly interval but lower the dose or
Yeah, yeah. So for example, if they've been on semaglutide 2.4, then for 6 months and doing stable, then drop them down to 1.7 every week for at least a month or two. And then if their weight is not increasing, then they can drop down to 1 milligram once a week, see how that goes for a few months or even longer. Again, there's no, this is all anecdotal from endocrinologists and weight loss experts that I've consulted with. There's not great evidence that this is necessarily the best way, but it makes some sense to reset the weight set point, go down as slowly as you go up.
Right, right, right. Yes, it's all, the set point theory is just so interesting. If we can really reset that by getting people to a better weight and keeping them there, that's, does the evidence support that you actually
Yeah.
can?
Well, it's
Mhm,
interesting. I watched a lot of lectures on weight loss before preparing this talk because I like to be over prepared.
mhm,
And one of them that I watched showed really interesting research that weight might not kind of reset for a good like 3 to 5 years.
mhm,
And so patients are chronically having to eat less than, so for example, if I was 150 pounds and I came down to 100, I would at least for 5 years have to eat 10% less compared to a friend who was always 100 pounds. So it's just, there's challenges that continue beyond, like I said, I've heard people recommend just staying on a plateau for 6 months, but there are challenges and studies that show that continues to be difficult to keep a lower weight compared to what you've been at before, even for many years after.
I can only imagine how validating it would be to, as a patient, to hear you say that. Because, right, don't our patients say to us all the time, I swear I eat less than
Yeah.
my skinny friends and I gain weight and they don't? And that's actually true. Quick question about the use of these in breastfeeding people. What do we know about that?
Yeah,
GLP-1s.
we do know that using them can decrease milk supply. It's
Mhm.
considered safe for the infant, I believe, but it's just that it can decrease weight supply and then, sorry, milk supply, and also, rapidly losing weight can also affect milk supply. So those are the bigger issues, the milk supply.
Okay, okay. And there were a couple questions in the Q&A about, could we see this slide again or this slide again? And I just will say that we will have the recording for all of this available to you, and you can go back and look at all of the content. So people, I think, were madly taking notes.
Yes, I know I have a lot of content and I talk really fast. So, but yes, I hope the slides are a useful resource.